we've brought together the Palliative and End of Life Care National Network that is organised through the Applied Research Collaboration and the National Care Home Network. And these two networks bring together researchers, practitioners, patient and public representatives and charities, all who are interested in these key areas of work around palliative end-of-life care and long-term care. And what we do is we build collaboration and innovation. We seek to learn together, improve care and optimize future research. And past collaborations have led to work that is absolutely grounded in the daily experience, but optimizes and exploits the fact that this is a national collaboration of researchers and practitioners. So this seminar is the second one, and this one is looking at end of life and palliative care in care homes. The third one will be on visiting and what we have learned about visiting and care homes since the pandemic. We start with Anita Peet, and we start with a study that absolutely brought to the fore what it was like at the beginning of the pandemic to be working in a care home and the challenges. We're then a piece of work presented by Anna Bone on the response and how to deliver systems of care that are integrated, and a sort of hot off the press presentation on CovPal, which is about current work and seeking involvement and comment, and then the curated discussion. Have the next slide, please. So I think Catherine might have already said this, but please put your comments and questions in the chat as we go along. And we've got people who are watching what's going on and trying to organize it so that when we come to the end of the presentation, Stephen Barclay, who with Irene Higginson leads the Palliative and End of Life Care Network, and Catherine Evans can then collate and put this to the panel and the different presenters. Please if you're not speaking, can you mute your microphone and have your screen off? The webinar is being recorded and will be available to everybody afterwards, and there is an evaluation form. And there are also, I think, requests as part of the presentations for expressions of interest in current work. So without any further ado, I'd like to hand over to Anita Peet. And welcome, Anita. Are you there, Anita? Ah, here we are. So Anita is, I haven't got your info, is the manager of Wren Hall, or chief executive of Wren Hall Care Home. Is that correct, Anita? Is that the right?
I'm the managing director of
Managing Director, thank you. And I have to say that it is such a privilege to have Anita here, because you will probably recognize her from the early reports of the pandemic as the person who the BBC went to and who saw it up close and personal, what it meant. And so I think it's always appropriate that we start with the people who are most affected. But Anita is a great champion for research and a great partner and collaborator, and we specifically really want her to share her views, which I think have been fortunately very influential. Thank you, Anita, to you.
Thank you. Thank you for those lovely words. Unfortunately, I wasn't the only one that suffered through the pandemic. I know that many colleagues have, and I think the important thing is we reflect and we learn from the great things that we did achieve. So thank you. So I'm going to talk through my experience, and the title of this is Researchers Are Saviours, and that's exactly how I feel about our research colleagues. And it was only through reflecting around what happened in the pandemic that I really realised how important and invaluable they were. Next slide, please. So this is Wren Hall. Wren Hall is a family, a real family. At the top left picture there, you've got my dad. He was a resident with us for the last 7 months of his life. And in the bottom left-hand corner, you've got one of our children, because we have a nursery on site. And that's Elisa's mum, and Elisa's mum works as one of our admins team. So it is a real family affair. And the other pictures just show the fun that we have. This is pictures from various care home open days. Next slide, please. So along comes coronavirus on the 27th of March 2020, and it was horrendous, wasn't it? It was like the blind leading the blind. We didn't know what we were doing. We had very sketchy and questionable guidance coming out from Department of Health. We were filled with anxieties. We should have been prepared and we weren't prepared, and we didn't really know what we were going to be facing. Next slide, please. So a colleague from a CCG said to me, what about setting up a WhatsApp group? I wasn't quite sure what it was going to do or what it was going to mean, but we set one up, and it was amazing because within 2 weeks we'd connected 257 people, which is the maximum a WhatsApp group can host across the sector. And it allowed us to give peer-to-peer support at a point when care homes were probably more isolated than ever before. Next slide, please. So what we were striving to get is some degree of optimism to find the courage to get through this pandemic. Next slide, please. And unfortunately, there were really bad times. I look quite scary there. It was probably one of the lowest times in my life. When this picture had taken, we'd lost 9 of our family members. That's how we refer to our residents. And we do view them as family members. But also it was horrific because the family that loved them weren't able to be with them and in the way that they usually are. So at Wren Hall, when somebody's dying, their family lie with them. We've got double beds so that the family can lie next to the person, they can caress them, and they can be close to them. And coronavirus took that away from everybody. So it was really devastating, and that's the lowest ebb. But next slide, please. These amazing people supported us. On the top left there, we've got Eric Fuster, and he is a water consultant who has worked globally through pandemics such as SARS, Ebola, and others. And he advocated zoning and cohorting. So we followed zoning and cohorting well before it was in the national guidance. Bottom left, we've got Adam Gordon, who is a consultant geriatrician, and he was the expert medical advice on our WhatsApp group. And he answered emails, messages, he still does answer the messages that come up on the WhatsApp group on a day-to-day basis. The other fantastic people there are Julian Mayer, Professor Julian Mayer, Neil Chadbourne, Elise, and I dread to think I've forgotten her surname, and Karen Spilsby, all who were absolutely amazing. They were on the WhatsApp group with us, and they were feeding us information at the point that we were at our lowest ebb. I was going into work at 3 o'clock in the morning. I was coming home and falling into bed at 11:30 at night. And we were posing questions on the WhatsApp group, and the amazing people that are on the bottom of that slide were the ones that were answering our questions. They were feeding us with the alternatives, current research, emerging research, and information that really helped us get through. You know, through this pandemic, there's been so much questioning and so many myths and so much controversy that some of this stuff was viewed as being propaganda. But when a researcher is telling you stuff, it's no longer propaganda. And so I'm going to shut up now and hand over to Elise, I think, who's going to tell you the wonderful work that she and others have done.
Hi, so I'm Alice Griffiths. I work at the University of Liverpool, and I'm going to talk to you about the first part of two studies that we did that kind of went side by side. So I'll speak about the first one, and then Rena's going to speak about the second one. So the first study was called COVID Search, which kind of stands for Seeking Answers for Care Homes During the COVID-19 Pandemic. So in terms of why we did this study, obviously Anita's talked quite a bit about the situation that we were going into at the time. And COVID-19 was bringing lots of challenges for care homes with screening residents and staff, diagnosis, management, and the clinical and workforce challenges that brought as well. And what this left care staff with was lots of uncertainties and questions about how to provide care for people and how to do that in the optimal way. We also know that residents are and were at increased risk of harm from COVID-19 due to their age and the likelihood of them having multiple conditions and also frailty. So as Anita said, there was the WhatsApp group that existed that was self-formed by care home managers and staff early in the pandemic that we were also in and collected some data from. So the aims of our study to identify what the care and organisational questions and uncertainties that care home staff had, what they were, and understand what information was needed to help us address these uncertainties and how this could help us provide support to care homes in the short, medium and long term. And obviously this was last March and we didn't think the long term was going to be quite as long term as it has been, but that was what we were aiming to do at the time. So in terms of our methods, the first thing that we did was exported weekly captures of WhatsApp discussions as text. So this was downloading all the content into Excel spreadsheets. So we had the content of all the messages and questions that people were asking. Secondly, we then removed any data where there wasn't an uncertainty or people weren't asking questions. So in amongst all of this in the WhatsApp, there's also people just chatting, saying hello, asking how people are doing. So obviously we didn't use any of that. The researchers then translated these uncertainties into questions because the questions that care staff were asking and the uncertainties that they had weren't necessarily framed in the way that you'd frame research questions. We then grouped these into initial themes. So sort of what kind of areas were people talking about the most? What kind of things were they saying were really important? So this includes things like supporting residents, diagnosis of and screening for COVID-19 and looking towards the end of life for people. We then identified whether the questions were background, so ones that needed to be worked on over the longer term, or foreground, those that needed immediate answers for care staff to enable them to successfully care for people in a way that met their needs. And then finally, we took those themes and worked on them using thematic analysis, where you group things together that are similar to have 9 themes, which were our final themes. So these are presented here. So the biggest one, so they go from the one on the top left is the one we have the most questions around, down to the bottom right where there was slightly less. So the biggest one was around supporting residents, relatives and staff. And other large ones were around maintaining an effective workforce, interacting with healthcare services. So how does social care and the NHS interact? Maintaining effective care, the impact on the organisation, enhancing information sharing and learning from other organisations, valuing the contribution of care homes, infection prevention and control, and symptoms and treatment. So today I'm just going to speak about the 3 where there were particularly large amounts of questions around end-of-life care. So what I've done is got some example questions that were raised from the WhatsApp group. So this is the first one around supporting relatives, residents and staff, which was someone asking for guidance around how to facilitate conversations about do not attempt resuscitation with residents. So care home staff were very aware that lots of people might need these to be in place for them, but the issue and the uncertainty that they had was around how do we facilitate these conversations with people who we wouldn't usually in other circumstances be having those discussions with. The next one is from symptoms and treatment, and was a huge worry for care home staff, and a question that came up over and over again, which was looking at patterns in the trajectory of COVID-19 for older people. Were older people experiencing the virus in the same way as younger people? Were they having the same kind of patterns? Was it possible to predict who might recover versus who might need to go into hospital, comparing to those who might be demonstrating signs that they were at the end of their life? And this was very difficult, particularly when a lot of the symptoms being respiratory meant that it was difficult to establish what was just from having COVID-19 in general versus what was showing that someone might be at the end of their life. In terms of maintaining effective care, this question asked what strategies are there that can lead to the highest reported quality of death for the resident or perceived levels of support from the relatives. So what are people saying actually made them feel relieved at a time that they were probably unable to visit or may have only been able to visit in the very last hours of their relative's life? And what can we do to make sure that people are having a good quality death even during the pandemic? And moving on from that, when people are coming in to visit at the end of their relative's life, how can we prevent transmission from those visitors coming into the care home? And the data that we had, this was last March till May, so obviously at a time when nobody was visiting at all, and there were very high levels of COVID-19 circulating. So preventing more COVID-19 coming into the care home via these visitors was a huge concern for staff. And another question that came to light was around the impact of resident adverse events and home-related adverse events if end-of-life medications were being reused, if they were available, because there was difficulties in getting medications into the care homes as quickly as people needed them. So in conclusion, the questions that care home staff were raising had 3 broad areas of focus. So it's diagnosis and screening of COVID-19, prognosis for older people, their residents living with COVID-19, and the effectiveness of interventions to keep people as well as they could be. The end-of-life care was a real concern for staff, firstly in terms of identifying who was at the end of their life to ensure that the appropriate support was in place for them and their family where relevant, and also identifying how to support them and their families through that time. What this study allowed us to do was identify a research agenda for care homes that was set by care home staff who've worked through the pandemic, and highlighted that care home staff experiences should be the focus of the evidence-based response that continues in care homes going forward. So just to acknowledge, I was one member of a very big research team, including Rena and Anita, who you just heard from Anita and you'll now hear from Rena. We were funded by something called Niche Leads, and the link to the website is there. And if you'd like to see the full results, we've published these now. The link's there, and I'll also pop it in the chat. And I'll now hand over to Rena, who's going to talk to you about the second study that followed on from our WhatsApp study.
Hello, can people see me?
Yes.
Yes, okay. Sorry, I was just having a bit of trouble finding the the Zoom buttons there. So good afternoon, everyone. I'm Rena Devi, and I'm going to share some findings from a research project where we learnt lessons from frontline care home and NHS staff during the first wave of the pandemic. So a bit of background and context. As Alice and Anita have highlighted, the WhatsApp group was a great resource for us as researchers to identify the clear research needs in coming from the sector. And a really clear research gap early in the pandemic was gathering learning from the first wave and having this prepared, having this ready to help care homes prepare for subsequent waves. So around about this time last year, the care home research team at Leeds and the National Care Forum came together to design a project which would address this need. So we designed a project which would capture learning around how do older people present with COVID and what is their illness trajectory, and also learning around how do we best treat and manage the virus in this population to A, help them to recover, or B, help older people to die well. And given the focus of this event this afternoon, I'm going to describe the findings that are relevant to end-of-life care. So how did we go about doing this study? This was a qualitative project which took place in 2 phases. During the first phase, we carried out interviews with NHS and care home staff who had experience of caring for an older person with COVID. And during phase 2, we presented the phase 1 findings to care home operational and quality managers, and we sense checked our findings. So we asked them, do these findings resonate? Are they relevant? And can you help us to identify any gaps in our work? The findings relevant to end of life were grouped together in 5 broad themes. So around understanding individual preferences, ensuring comfort at end of life, restricted family visits, supporting staff, and also supporting care home organisations. So within our first theme, our participants highlighted the really important need to have advanced care plans up to date so that any inappropriate treatment could be absolutely avoided. And this was especially important given that the trajectory of COVID, we were learning at the time, was completely unpredictable in this population. And actually, the decline can be very rapid. So our participants emphasised that because of these reasons, it's really important to have key discussions and decisions happening before the event of end of life. So our participants emphasised that in particular, knowing whether or not the older person would want to go to hospital to receive active treatment, their preferred place of death, and also knowing are there any cultural or spiritual wishes that the person has for their end of life. Our participants emphasised that documents with this information need to be accessible and easily available to both relevant care home staff, but also NHS staff such as GPs and paramedics. And also, given that staff were operating in the pandemic context, they needed to give some consideration to how wishes could be appropriately fulfilled within the restrictions of COVID. And our participants also described they were collecting this information in really pressured situations. So gathering this information efficiently was really important, and our participants described that the respect tool was a good way to do this. Our second big theme was ensuring comfort at end of life. We learned from our participants that there were 2 big challenges around this during the first wave. The first one was that there were shortages in end-of-life medicines during the first wave, and this created distress both to the person dying but also to the staff caring for them. A second big challenge that was experienced mainly in residential homes was that staff were experiencing delays in waiting for community nurses and palliative care specialists who would visit the home to administer end-of-life medicine. We heard different strategies which were used to help address these difficulties. Firstly, anticipatory prescribing was used, where the GP would prescribe medicine as a just-in-case option. Reusing medicines which are no longer needed by individuals for other residents in the home. And thirdly, in residential homes, care staff told us about using lorazepam, which could be used orally or placed under the tongue if the older person was not able to swallow. And this helped alleviate some symptoms whilst waiting for NHS staff. Our third big theme was around restricted visits. So this has been a much debated and discussed topic throughout the pandemic. And so it's no surprise that this was also featuring as quite a prominent theme in our data. And frontline staff emphasised that this created a lot of distress, both for the person dying and their relatives who couldn't be there with them. And this can create quite complex and difficult bereavement for relatives. And as Alice described earlier as well, this data was collected during the first wave of the pandemic. So there weren't any sociable visits, but there were some care homes did allow end-of-life visits to take place. But these were done in very restrictive ways to help minimise any risk of transmitting COVID. So different measures were used for end-of-life visits, such as restricting number of visitors, limiting the duration of the visit, explaining risks, taking temperatures, wearing PPE, asking relatives to self-isolate after the visit, and also putting in place designated entrance and exit points in the care home. Another key finding within this theme was that care home staff told us about how restricted family visits and lockdowns created a lot of work for care home staff in terms of keeping in touch with all the families of residents in the home. So this created a lot of work, as you can imagine, and our participants told us about they had to put in place a designated staff member whose sole responsibility was keeping in touch with families, giving them updates on their relatives, providing bereavement support, and also checking in with family around end-of-life care planning. Our fourth theme was around supporting staff. So again, it wasn't a surprise in the data to hear how COVID-19 is having such a shocking and devastating impact on staff. And in particular, care home staff were highlighted, as Anita described as well, that when losing residents in care homes, staff have had got to know these residents over a really long time, and to lose multiple residents in a short space of time had a very hard impact on the staff. And our participants described different things that were used in the first wave to help support staff through this. So these were strategies such as allocating time for debriefing, bereavement and counselling support, feeling that staff were having good teamwork, good team relationships, being part of support groups, feeling valued, and allowing time for staff to heal and rest. Another way that staff were supported was through providing end-of-life training. So staff told us about palliative care staff in the community, and also local hospice community staff coming into care homes and providing training. And different things that were highlighted in our data were things like preparing staff to do end-of-life planning, verify deaths, and also correcting any misconceptions around end-of-life medicine. Our last theme was around supporting care homes at an organisational level. So our participants described that in some local areas there was a local death verification service. And this helped to take some pressure off GPs and nurses who were previously needed to visit care homes in person to verify deaths. So this helped to alleviate some of that pressure there, but also verify deaths in a timely way. This was particularly important in residential homes where a registered nurse isn't on site. The other way that care homes were supported was we heard about changes made in the way that GPs could issue notifications of expected deaths. So prior to the pandemic, these had to be done in person and extended for only 14 days. And changes were made that the GPs did these virtually, and also expected deaths could be notified. The notification period could be 28 days as opposed to 14. And this just helped avoid the risk of investigating any unexpected deaths in the care home. So just to conclude, that the key findings were the importance of individual advanced care planning, ensuring comfort for older people, the strong need for family visits at end of life, looking after staff emotional and physical well-being, and also supporting care homes at an organisational level. And also to acknowledge our funder, the Dunhill Medical Trust, the participants who gave their time to this project, and I was part of a team that carried out this work. We have the full findings available online in a report. The link is there, and I can paste the link into the chat as well. Thank you.
Thank you very much, Rena. So Rena's just put up any questions, so please could you pop those questions into the chat? And I've seen just a request, yes please, Rena, could you paste that link into your chat? So I think we've set the scene. I think it's already raised lots of questions about how we even start conversations with care homes as partners in care. And this segues, I think, really nicely into the next presentation, which is being presented by Anna Bone from King's College. And Anna is a postdoctoral research associate at Cicely Saunders Institute, King's College, has a background in public health, and have worked on a range of research studies looking specifically at palliative care for older people. We're delighted that she has been able to join us, and as I think the title itself shows, that this is looking at it from the service response. So Anna, if you're happy to take over, and as I say, please do keep asking lots of questions. We've got people who will try and pull them together to summarize if lots of people are asking similar things. Thank you. Anna, thank you.
Thank you, Claire. Can I just check that you can see the slides okay?
Yes, we can.
Brilliant, thank you. Good afternoon, everyone, and thank you for that introduction. As Claire said, I'm Anna Bone. I'm a postdoctoral research associate at the Cicely Saunders Institute at King's. And the title of this presentation is Can't Do This Alone, Integrated Community Palliative Partnership. What have we learned from COVID? So I'm delighted to present to you some preliminary findings from the ICPP study. I'm presenting on behalf of a wider team that you can see detailed on the slide. And this study was funded by the Dunhill Medical Trust and Cicely Saunders International. So the first point that I'd like to make is that care homes are important settings for end-of-life care. A couple of years ago, we examined trends in place of death, and we projected that by 2040, so in less than 20 years' time, care homes could become the most common place to die. And this is due to rising proportion of people dying in care homes and the continued aging of our population. On entry to a care home, a resident, it's estimated that they have an average life expectancy of between 12 and 24 months, although these estimates vary. It's common for care home residents to have high dependency. Often they'll have complex needs, and many live with multiple illnesses and cognitive impairment. We know that as a person nears the end of life, the number of unplanned hospital admissions rises, and this is true for people living in their own home as well as people living in care homes. And of course, during the pandemic, we've seen that care homes were disproportionately affected, with a staggering 25,000 excess deaths in England and Wales in care homes in 2020. So the relevant policy context for this work is, as I'm sure you know, in the NHS long-term plan that was published in 2019, there was a commitment made to roll out the framework for enhanced health in care homes across England between 2020 and 2024. And I'd just like to highlight the first couple of sentences from the framework document, which states that people living in care homes should expect the same level of support as if they were living in their own home. This can only be achieved through collaborative working between health, social care, voluntary community and social enterprise sector and care home partners. So collaborative working and improving integration between the different partners is a key tenet of the framework for enhanced health in care homes. And while there is a section on palliative and end-of-life care in this document, there is limited detail on how palliative care services are best integrated in care homes. And if we look to the current literature and the evidence on effective models, a recent systematic review by Carpenter et al., published last year, identified 13 trials on the effectiveness of palliative care in nursing homes and concluded that there was limited high quality evidence of the effectiveness of palliative care interventions on nursing home residents' end-of-life outcomes. A new and interesting model, the needs rounds model, has been investigated, which is a triage meeting between care home staff and specialist palliative care clinicians to review residents who are at risk of dying and without a care plan in place. And this was studied in a trial in Australia and found that it reduces length of stay in hospital and improves symptoms. So this is a promising model, and it's currently being examined in the UK by Liz Forbat and her team. So it'll be interesting to watch this space. We can also draw on evidence from other community settings, looking at palliative care interventions for similar populations. For example, Catherine Evans has led a trial looking at community-based short-term integrated supportive and palliative care for frail older people. And you can see in the model development here on the figure in the slide that this model looked at episodic specialist palliative care input integrated alongside ongoing support from primary care, and to be involved at particular points in the illness trajectory of the older person where there was periods of decline and acute illness. So this was modelled for this population particularly, and which differs from the sort of standard traditional palliative care model based on the cancer trajectory. So this is hot off the press and published yesterday in the International Journal of Nursing Studies. So if you're interested to read more, I'd encourage you to find that paper and read it. But overall, we can say that there are gaps in our knowledge around how palliative care is best integrated into care homes. So that's what this study seeks to address. So the study aims to explore the scope, feasibility and potential scalability of an integrated community palliative partnership, incorporating specialist palliative care, primary care, social care and specialised nursing support for older people with advanced disease in care homes. And by this we mean nursing and residential homes in the South London region. So the idea for this study was conceived before the pandemic. It's a participatory study, and the main parts of the study in terms of the data collection are shown in green. So that is individual in-depth interviews with a range of staff, residents and family, and then the findings of these interviews to feed into a series of co-design workshops with stakeholders. And the ultimate aim is to develop a conceptual model to identify the key elements of the service, how it's expected to work, and the intended outcomes. And then, of course, the pandemic arrived last year, and with its many impacts, also provided some challenges for the setup and delivery of this study, but also provided some opportunities to understand the impact of COVID and learn from these experiences. And I'm going to focus on the preliminary findings of some of the in-depth interviews today. So I'm presenting on 14 interviews that we held virtually with a range of health and social care professionals. I won't read out all the different roles, but you can see that we were able to interview a range of multi-professional groups. You can see in the black box here that care home residents and family members, we weren't able to access these groups for these interviews, although these are obviously a crucial voice to include in the development of any services. So just to bear in mind that that's a limitation of the preliminary findings that I'm presenting today. So these are some of the early themes from the interviews and some of our engagement with other stakeholders. So it was emphasised around the complexity of needs of this population with multimorbidity and commonly severe frailty. And we've also already heard from Rena about the atypical presentation of COVID-19 and the unpredictable illness trajectory. So with all this uncertainty, it was advocated the need for parallel planning, whereby the professionals would plan for both the eventuality of recovery, but also at the same time plan for the possibility of further deterioration and death. During the pandemic, it was noted that there was a reduced assessment of residents, and particularly by people who knew them well. So that was both the healthcare professionals that were no longer able to visit in person, but also family members who knew the residents really well and understood their baseline. And this was particularly exacerbated in the first wave, when there was a trend towards quickly discharging people from hospital into care homes where they weren't previously resident. And this created a challenge with care home staff not knowing those residents or their baseline. And this was described as leading to missed problems for residents and some situations misdiagnoses. There was also comments around the narrative around family being seen as visitors rather than active participants in care, which underplays the key role that they often play in the care of the care home resident. And in terms of service responses that worked well during the pandemic and the crisis seemed to mobilise more joined up working. So for example, new educational meetings set up, for example, between GPs and hospices, where they would discuss ethical dilemmas and issues and other concerns that were arising, more multidisciplinary team meetings, and new hotlines to medical consultants for rapid access to senior medical support. And we've heard already about WhatsApp groups in a different part of the country, but this was also seen to be really helpful in supporting care homes in the London area. So the pandemic enabled some flexibility to make changes, and there was a sense that this was with more of a shared vision. For example, the shared notion that care home residents should remain in their care home where possible and not be transferred to hospital where it was seen that the risk of infection was high. There was also expansion of existing initiatives to support care home staff, for example, Project Echo, which is facilitated using teleconferencing facilities to bring together care home staff with specialists in palliative care to discuss particularly difficult cases and provide some education and a community of learning. There were also examples of different ways of providing bereavement support to both staff and families. So I'm just going to end with some early recommendations or reflections on thoughts on possible solutions. So the idea that we need to support sustainable new models of integrated working, and it was emphasised that care homes must be equal partners in this process. Regular assessment and monitoring of care home residents has been highlighted as being really important, and the pandemic has really shown this. And using tools that have already been developed and validated might be useful here. For example, the integrated patient outcome scale. The need to ensure rapid access to treatment and services, including out of hours, was emphasised as being really important. And finally, ensuring that care is individualised and tailored, and also includes rehabilitation as well as palliative care. So I'm going to leave it there, and these are the references referred to in this presentation, and just to say thank you for listening, and I'm very happy to be contacted after this event if there are questions that are left outstanding.
Okay, thank you so much. And already we've got some sharing of information going on as you were speaking. Delighted, sort of, I think, a very good example of how the pandemic has accelerated conversations and openness that possibly wasn't there before. It's just a shame it took a pandemic to initiate some of those. Thank you, Anna. And now I'm going to go into our last presentation before we go into the conversation. So please, it's not just questions that we want in the chat box. We're just really interested in hearing your comments, your views. I deliberately asked a bit about doesn't needs rounds sound like hospital rounds, and I think that's I've had some helpful feedback on that. And also just to recognize that this is a group of with huge information resources. Although we're talking here, there are people who know as much who are listening. So please do just feel free to contribute your thoughts as well in the chat. So I'm delighted to welcome Catherine Sleeman, and who is I must get your special title, is the Lang-Galaska Chair in Palliative Care. I think that's still quite recent, Catherine, so I think we can still say congratulations on your appointment, which is lovely for palliative care to see this kind of investment. And Catherine is also an NIHR clinician scientist and an honorary consultant in palliative medicine at King's College Hospital Trust. And we've invited Catherine to present on a study that is really just getting off the ground, and there's as much to seek comment and engagement, as well as share thoughts and ideas. And that's partly the format of these webinars, that we try and keep a conversation going. So thank you, Catherine.
Thank you so much, Claire. Can you see and hear me?
Yes, indeed.
And can you see a full screen slideshow?
Yes.
Perfect. Thank you. So yeah, exactly as Claire says, I'm here to really sort of start a discussion about this new study that we have just got off the ground called CovPal Care Home. So the full name of the study is the Rapid Evaluation of the Care Home Response to the Need for Palliative and End-of-Life Care during the COVID-19 pandemic. It's called CovPal Care Home because it is the sort of daughter study of a study that was called CovPal, which looked at provision of palliative care from hospice and palliative care providers during COVID. And while we were doing the CovPal study, really getting lots of information about what hospices and palliative care teams were doing, we realised that there was a massive, massive gap in our knowledge, which was around care homes. And this study aims to fill that gap. The study was funded by the NIHR Policy Research Programme, and it's really important to us that it was funded by the Policy Research Programme bit of NIHR, because we are very, very much aiming to do a piece of work that has policy relevance and implications. I lead the study along with Catherine Evans, and the co-applicants on the study are listed here. I don't really need to say anything to this slide. We all have heard this afternoon that COVID has had a devastating impact on care homes. We all know that. Not only many deaths have occurred of care home residents, as Anna told us. But actually, it's not just about deaths, as we all know, because many more people than those who have died have experienced symptoms and distress. And I guess while there has been a lot of media and a lot of policy focus during the last year, 14, 15 months on care homes and COVID, most of that focus has really been on an infection control and prevention of infection. And there has been relatively little examination of provision of palliative and end-of-life care in care homes. And this is what our study aims to look at in depth. We're not just looking back, though, at what has happened during COVID. We really want to use that information to look beyond COVID and to enable us to build that better provision of palliative and end-of-life care in care homes going forward. Anna already pointed out very nicely that care homes are one of our main providers of care for our aging population. There are many more care home beds than hospital beds, and we really ought to be scrutinising and examining how palliative and end-of-life care is provided in care homes so that we can understand where we might need to improve things or invest or resource. So I just want to briefly tell you then about our CovPal care home study. The overall aim is to examine the response of care homes to meet that rapidly increasing need for palliative and end-of-life care that occurred for residents during the pandemic, and to use that information to make recommendations for policy. So there are several research questions, and I've put some of them here. So first of all, what were the facilitators and challenges to palliative and end-of-life care provision in care homes during COVID? What helped and what didn't help? Using that information, how can we optimize end-of-life care in care homes, both now and thinking about the future? A lot of people have mentioned workforce, and there was also some focus in the chat about it. And we're really interested in understanding the impact of the COVID-19 pandemic, and particularly the impact of the implication in terms of palliative and end-of-life care, what that impact was on the care home workforce, including resilience, well-being, retention, and educational needs. And we're also looking at, well, what are the longer term implications then of the COVID-19 pandemic on care home provision of palliative and end-of-life care? So thinking even about sort of changing attitudes and behaviours towards care homes as a key provider of palliative and end-of-life care, and also looking very much at that integration piece. So what can we learn about better integration across health and social care? So there will be two main work streams to this study. The first is an online rapid survey to understand care home provision of palliative and end-of-life care during COVID. So in this survey, we are seeking to recruit about 400 care home senior staff. That's thinking about adult services, both with and without nursing. And in this survey, which will consist of both coded data, so tick box type data, as well as the opportunity to add free text, we'll be exploring things like the use of guidance on palliative and end-of-life care, what helped, what didn't, on that perception of integration with wider health and social care services. We'll be asking about availability of medicines and equipment. We know that in the palliative care sector, there were huge problems in terms of shortages of medicine, shortages of equipment, and we want to know a bit more about whether those problems were also experienced in the care home sector. We ask about communication with families, both before and after bereavement, about visiting arrangements, advanced care planning, which has already been mentioned today. We're really particularly interested in service innovations. We know that many care homes innovated rapidly at the start of the pandemic, and we want to find out, well, what did you do? What did you find helpful? And actually, what did you find unhelpful? What would you not do again? So that's the first work package, which is this online rapid survey. The second work package is then in a much smaller sample, just 20 to 24 care homes, will do some in-depth online or telephone qualitative interviews. And there we really want to drill down on those challenges and facilitators. What helped provide good palliative and end-of-life care in care homes? What hindered that? And what do we need to be thinking about for the future? So this is a slide just to point out our timeline and sort of where we're at. So it's a very short, quite rapid study. It's a 12-month funded study, and it started in January this year. So although we consider ourselves still very sort of early in this study, actually, you know, we're not too far away from the end as well. So here we are in May, and we have spent the past few months doing quite a lot of talking to our PPI group, so to caregivers of people who are care home residents, and also talking to our care home expert panel and refining that that initial survey that for care home staff. I'm really happy to say that we have now gone live, and we've disseminated and started recruiting to that survey, and the recruitment will be open for this month and next month until we reach that number of responses that we're looking for. We are also about to go live with our qualitative interviews. So these will be in the survey. There is an option to tick, are you interested in being contacted about a further in-depth qualitative interview? And it's from that we're identifying people to interview for our work stream 2. The other main thing that I want to point out using this Gantt chart, apart from the fact that it's a very rapid study, is that yes, we will be publishing peer-reviewed academic papers in the normal way, but in terms of really trying to produce data that is useful and usable both by people, by the care home sector, and by policymakers who might be able to change things at a different level for the sector, we'll also be focusing very much on reports, on plain English summaries, and on policy briefs to try and drive that impact. So last, I just wanted to say, well, we would love to have your help. As Claire said, both help in terms of understanding, you know, what you think are the priorities, what your ideas and thoughts are about what helped or hindered provision of palliative and end-of-life care in care homes during COVID, but also particularly, we would love you to fill out our survey. So you may have seen this flyer come into your email inbox if you work in a care home. This has been, we're partnering with various organisations like the Queen's Nursing Institute, ADAS, Enrich, the CRNs, and we are, so you may well have had one of these flyers pop into your inbox. If you have, or if you haven't, we would really love to hear from you. If you hold a senior role or in a care home, you might be a manager, a deputy manager, a team lead, please get in contact with us. The best way to do that is by emailing this address, and we can pop that into the chat. So palliativecare@kcl.ac.uk, and with CovPal Care Home in the subject. And we would love to be able to send our survey to you so that we can include your views. We know that care homes are incredibly important settings for end-of-life care, and we also know that very few studies still have examined palliative and end-of-life care in care homes. We really want to hear from as many people as possible about this in this survey, so that we can ensure that a wide variety of views are then taken into consideration for those subsequent policy shaping stages. That was all I was going to say, but I also have my personal email address at the bottom of the email. If you have any other questions or comments on the study, we'd love to hear from you. Thanks.
Okay, thank you, Catherine. And we'll leave that slide up just for now so you can see it. There are some questions about the reach of the survey, which we can pick up later, and also some requests that can we share published papers, and I'm suggesting that we could do some preprints as not to upset journals, because I think accessing resources for care homes is a big issue. So we're now we're doing not doing well. We're about to go into our curated conversation, where I think this, as I say, this is as much about sharing learning and exploiting the fact that we have this amazing coalition of people interested in care homes and or end-of-life care. And even in the comments, there are a lot of initiatives, and I just sit here and think that is one of our jobs, is to make sure that great work and work that is promising doesn't get overlooked, and this is a great forum for that. So I'm now going to give the conversation over to Catherine and Stephen Barclay. So Catherine's from King's College London and part of the Cicely Saunders Institute, and Stephen Barclay, who leads with Irene Higginson, who's also at South London, the National Palliative and End-of-Life Care Network across the Arcs. So I'm going to hand over to Stephen and Catherine.
Great, thank you, Claire. So what we would like to do now is just to continue this conversation. I think, as Claire said, it's just absolutely wonderful to see this coalition of individuals from care homes, from palliative care, from researchers, from primary care coming together. So we'd now like to sort of pick up on some of the comments on the chat that we're going to pose to our speakers. So what I'd like to do is, can I just ask our speakers to put their cameras back on again so that everybody can see them? Lovely, thank you. And Anita, if you feel able to do that. Brilliant, thank you. And Stephen, I don't know if you wanted to say anything before we started, was there?
Yes, I think just to say thank you, Catherine. So perhaps just to mention that, as Claire Goodman has kindly mentioned, that there is a National Institute of Health Research funded collaboration for palliative and end-of-life care, as there is a network for care homes. And this is a great opportunity for this joint event. And together with Professor Irene Higginson, in the palliative and end-of-life care space, we are keen to support, enable, and develop clinically, practically useful applied research. So I think there's some really good pointers here from the conversation. Catherine.
Thank you. So we've been busy trying to collate the chat and looking at the various themes and some of the key points that are coming up. And one of the first things I think to ask of our speakers, our panel, is about care homes as partners in care. And there's been several comments in the chat, both of things working very well in terms of partnership working, and also examples of where things have been imposed. So Helen Brereton from Trinity Hospice in London talking about an enhanced support framework in care homes that was what she felt was quite imposed by the CCG. So what would be helpful to begin with is to reflect on how can we work in a way that does ensure care homes as partners in care. So who'd like to go
on,
first?
Anita.
Yeah.
I think we have to start from a place of mutual trust and mutual respect. I started my life off as an NHS burns and plastic specialist nurse. I then worked in intensive care, and everybody thought we were wonderful, you know. There's so much respect. I went into social care, moved to the dark side, and nobody wanted to know me. Everybody thought I was just wiping bums. I was, you know, the lowest of the low. And quite frankly, I did my degree because I qualified as a registered nurse with no diploma or anything. So I did my degree to basically say to people around the table, the strategic tables I sat with health and social care, to say, you know, we're just as good as you. But every day in my 32 years in social care, I felt I have had to prove myself because I'm not seen as an equal. And quite frankly, colleagues should be ashamed, because that if they make me feel like that, they're making other people feel like that. And so we need to change that. And I don't know how and when the system's going to change. People are going to change. But we have to be seen as equals. And unless we are, then partnership working is not going to exist. So, you know, that's what it takes.
And Anita, can I ask you, what needs to happen to be seen as equal? What is the barrier now that stops that from happening?
I think, so one of the things is, I think we need a specific development program for registered nurses working in care homes. There are many providers that employ nurses that don't understand what their nurses need in terms of development and CPD. So that's one thing. I think nurses social care nurses need to recognise that what their knowledge base is, and to speak up, because a lot of nurses are uncomfortable doing that. They don't know. We don't know what we do, you know, what we know, and others don't know. So that's a challenge. And I think we just need an invitation to the table. And the fantastic, you know, I cannot speak highly enough of Rena, Alice, Neil, Julianne, Karen. You know, they all include us, and they're with us, and they listen to us, and you know, they encourage us, and that's amazing. But equally, when we're given an invitation, we have to step up. We have to go, you know, however daunted we may feel, we have to go to the table and we have to speak out.
Thank you. Yes, Rena, do come in.
Yeah, I'd just like to add a little comment as well to the question about partnership working. So the work Alice and I did with Anita around Search COVID and Less COVID, this was out of a partnership that we called Niche Leads in Leeds. And this is nurturing innovation in care home excellence. And we work directly with care homes in partnership, addressing the questions that come out from the sector. And yeah, so that partnership working really influenced our work during COVID as well. So the Less COVID project, that was done with the National Care Forum, and we were equal partners throughout the project. Yeah, so just to sort of give a little shout out to Niche and that sort of partner working that we do.
Thank you. And I can see in the chat the flagging of the Queen's Nursing Institute. So they also have a care home network for nurses in care homes. That is, I think, opportunity to begin to give that voice, Anita, that you were saying, as having representation at that sort of level. I'm just having a look.
Catherine, Catherine Sleeman, do you want to come in? I think you're raising your hand. Catherine, come in.
Yeah, just briefly. Anita, what you just said is so powerful, and that's echoed in the chat, many people agreeing. It beggars belief, doesn't it, that you don't feel as though that people are listening, that they respect you, especially given what we know about how society is changing and how important the care home sector is. And what I was reflecting on was, you know, in our study, like, how can we help get these voices out? And I was reflecting that the sorts of things we're looking to do in our study are not just say, oh, this piece of paper worked, that piece of paper didn't work, but actually what other much more integral things need to change. And actually, I would love to interview someone like you to say these things, and we can say, look, this is a massive problem. Actually, giving care homes different bits of paper isn't going to work if actually underlying all of that, people feel undervalued and as though they don't have a seat at the table. So I just wanted to say thank you for making that point so powerfully.
Stephen.
I think that's really helpful and a really powerful point. Can I link to that one of the questions or the comments in the chat about feeling done to, and the experience of actually this may be one that the colleague from Trinity Hospice, I don't know whether you'd be happy just to say a little bit about that, but clearly the CCG thought it was a good thing, commissioned you to do good things in care homes, and it wasn't always well received. So is that colleague still?
Is Helen Burton? Yes. Do you want to?
Yeah.
Helen, would you
Hi.
like to?
Hello.
Helen, hi. Do you want to
Hello.
say a bit more? Because this links in also with comments about the enhanced health in care homes that we might come on to in a minute. So over to you, Helen.
I think it came from a very good place, but I think, and obviously in recognition of the fact that the care home sector had fared very, very badly within the pandemic, we were asked to step up, I suppose, our support, which we were already giving to all of the care homes in our catchment area. But what we realised when we started sort of following what had been decided as the enhanced support was that actually the care homes hadn't been involved in any of the discussions around what they needed. And in fact, they hadn't even been told about the project. So here we go, start calling everyone, oh, we're here to be helpful, and we're going to call you every week, and we're going to join your MDT, and we're going to provide teaching 3 hours every single month. And the care homes were like, what? We didn't even know about this. And what we've realised is actually there isn't such a thing as one model fits every single care home, because each care home in our catchment, even in the same area, they all have different needs. So we're having to rapidly adjust and make sure that what we're offering is actually what is needed, rather than just some off-the-shelf package that isn't going to work really.
Helen, that's really helpful, and I think from comments in the chat that resonates with people. Perhaps linked to that, could we ask for whether the enhanced health in care homes, which I think has got renewed energy in many parts of the country, is that, and has a specific end-of-life care component, is that going down equally spectacularly as it perhaps did in some care homes? Are there comments on that? Because this is a major national initiative. Anita?
Yeah, I mean, it's a great initiative, isn't it? If we look at, I've been in the sector 32 years, and, there's been times that, and I'm not exaggerating when I say this, there's been times when we have sent our family members to hospital, and a young doctor's looked at them, seen how wrinkled they are, and have sent them back. No treatment, no nothing. And, so that has happened. There is marginalisation of those living in care homes and those working in care homes, and we have to change that. However, if we look at what happened over the pandemic, we were asked to advance care plan. Well, it was badged as advanced care planning, but to me, an advanced care planning is, what is it that I really want? What is going to make me feel fulfilled so that I can have the best death that I can have? That is not what we meant when we were asking care homes to write advanced care plans. What we meant is do a DNAR, stop people going into hospital and dying in hospital. The two things are very different. And so if enhanced health in care homes is going to be about ticking a box to make sure that we're doing something that should be done, but actually it's for the wrong reasons, then I'm not supportive of it. If it's about giving the best care possible to the people living in care homes, our older generation, who, have probably fought in 1 or 2 world wars, then I'm all for it.
Thank you, Anita. I don't know whether other colleagues want to come in on that.
Anna, I don't know if you'd like to come in and just your reflections on this conversation from the Integrated Partnership Project.
Thanks, Catherine. I think I'd like to hear what other people's experiences are around the country, because I'm sure there are lots of people on the call who can input more valuably than me at this point. I think on the point about the valuing or mutual trust of care home staff, I just want to mention that I think that was probably the most commented on thing in the interviews as a final point, was how we need to value care home staff and the incredibly important and valuable work that they do. So I guess this is a moment when with COVID, people are really recognizing the importance of that, and so yeah, it's timely point to be kind of thinking about this, an opportunity for change. But in terms of the enhanced health and care and care homes, I think, yeah, I would really like to hear from others on this call.
So if people please do put comments in the chat about the enhanced framework for care homes, because as Stephen said, it is a huge national initiative that is being rolled out quite rapidly. So there is an opportunity for us to have some impact on that in terms of how does it need to be implemented well. I think as Helen Brewerton said, it's coming from a well-intentioned place, but how can we ensure that those intentions are actually realised? And if anybody else has got thoughts that they'd particularly like to share with the group now and unmute, then do please put your hand up or put the comment in the chat. I think one of the other areas that I felt was very, very striking at the beginning of the presentations was Anita's beginning in saying we are family, in describing Wren Hall as the care home that Anita manages. And I suppose what I was very, very struck by and put in the chat is about the well-being of staff in care homes, supporting bereavement, and what are the messages for policymakers to foster resilience and prevent burnout. So just what needs to happen next? Anita, you put in the chat that this was something that was going to go on for a long time. And I wondered, what are those messages that we need to be getting across to policymakers about how do we foster resilience in our care home workforce and prevent burnout?
Do you want me to come in, or do you want me to
Yes,
let
I
somebody
do.
else?
Yeah. No, that would be fantastic.
So it's just timely because I was asked to comment on a paper around burnout, and as I'm reading it, it actually gave me a lump in the throat, because I realised that actually many of my team are experiencing burnout now, and it's gone unnoticed until I read this paper. So I think, you know, there's a lot of learning to do. So the burnout can be, you know, even for new staff joining the organisation, because the more experienced staff who are mentoring them are burnt out. The new staff are floundering because of ineffective communication, ineffective support, lack of information, lack of clarity. So that sort of thing causes burnout even before people have really got their feet under the table. And for those that have got their feet under the table, you know, there's that, well, how much more can we take? So this is going on and on and on, and we don't know what the long-term effects of wearing PPE are going to be. I don't know whether any research has been done in theatre staff or staff that work in theatres, but you know, I think there's just so much that is going to unfold. There are some staff that I found have been tremendously resilient. There's others that have broken and have taken a lot of time to be able to just function, and they are functioning, but they're not their normal selves. And it's about, what am I going to do as their employer to support them? So I've got a lot of thinking to do, and hopefully others will recognise that there is burnout, but we need to do something. What we do, I'm not quite sure.
Thank you.
I think, Justine, you've raised your hand.
Yes, I have.
over to you.
Hello, my name is Justine. I work with Hertfordshire Community NHS Trust, and I've recently started in the role of the senior care home practitioner. And we are, we've got the opportunity to implement the enhanced health in care homes program in the care homes. And as it's very interesting hearing about how other people are finding it, the challenges, and care homes feeling like it's being imposed on them. And for some of the care homes, we were also finding that, but then others are quite open and willing to work with us. We found that the GPs who are more aware of the program and they maybe they let the care homes know. So because the GPs already have that relationship with the care homes, then the resistance is less. But also some different PCNs are doing it differently. And where I work, we're covering 2 PCNs, and one of them has employed a care coordinator who coordinates for the whole PCN. So that has worked out really well because they are working with all the different care homes, and then it doesn't seem disjointed. But then in another locality, the GPs are not, the PCN is not that well coordinated, and each GP surgery is doing their own thing, which then means we have to go in and introduce ourselves to the care homes, and then we are introducing ourselves as well to the GPs. So there's a lot of introducing yourself and explaining what you do and all that. Yeah, but on the whole, I think once the care homes understand what you're about, they are open and they believe this is going to be a very helpful role for them. Thank you.
Justine, that's really helpful. Thank you. And one of the comments coming up into the chat is that we're in danger perhaps of being a bit of an echo chamber, that everyone on this call probably by definition is very aware of and committed to optimizing palliative and end-of-life care in care homes. And I think the question that Justine, you've touched on there, and our Gold Standards Framework colleagues have touched on is how do we stop preaching to the converted and reach out to that entirety of the care home sector, because probably the care homes that colleagues work in here are doing a much better job because of the commitment to it. I'd be really interested in comments on that. How can we engage with those who most need the support and encouragement?
Thank you. So we've got 5 minutes left. We wanted just to take a little bit of time also to be thinking about the priorities for research going forward. So very much sort of continuing this conversation. So both in terms of priorities for research, as well as some of the implementation, I suppose, of existing good practice and the existing evidence base. I've been very struck in the chat about mentions of things like the Gold Standards Framework, the use of the respect tools, use of things like the Marie Curie's Echo as a way of supporting practice, as well as the WhatsApp group that Rena and Alice talked about. So Rena and Alice, maybe to come to you first about what are your thoughts from your research about what are the priorities next to be taking forward research, the learning during the pandemic?
I think from my perspective, a lot of the focus is around how we look after staff now. Like Anita was just saying about burnout, that's certainly where Rena and I have kind of been focusing our work recently. And I think a challenge for us is it being seen as important to funders when there are much more urgent priorities, and care staff wellbeing, they're still working, they're still present, and that's kind of not seen as an immediate challenge when you've also got how do we address these very immediate concerns around COVID-19 that are still continuing. So it's certainly not something that I think is going to be easy to get funded, and that's been our experience so far. But yeah, in terms of how do we support staff to deal with the grief and the horrendous year that a lot of them have had going forward, because as Anita says, some of them are fine now, some of them are less fine now, and we don't know what that's going to be like in 12 or even 24 months from now. So that, I would say that's the main priority for where I'm looking. I think similar for Rena, but I'll let her.
Rena, did you want to come in?
Same as what Alice has said, really, but another topic that I think is really important and highlighted in our Less COVID findings wasn't presented today because I focus only on end of life, but in some of our other parts of that project, our participants were describing really needing to investigate how best to rehabilitate the people that have recovered from COVID, and also other older people who didn't contract COVID, because the periods of isolation and inactivity have really had a detrimental effect on physical and also emotional and cognitive well-being. So some rehabilitation is really needed as well.
Thank you. Very important comments. And I can see in the chat other areas, important areas of research. So from J.O. Thompson, I think that's Jacqueline, isn't it, from Dundee, a nurse consultant for older people, about the use of remote technology to holistically assess care home residents. And I have to say, we have a large research program called Embed Care, Empowering Better End-of-Life Dementia Care, which has a component of the intervention is trying to do exactly that, the remote assessment using an existing validated outcome measure, the Integrated Palliative Care Outcome Scale for Dementia, that Mev was also posting in the chat about, and that Anna mentioned in her presentation. So please do put examples of research that you have that's ongoing in the chat. Part of this conversation is for us to have an understanding and to share research that's underway, or research that's planned, or research priorities. And then we've got about a minute left. I'm going to hand over to Stephen very quickly, just to wrap up.
Thank you, Catherine. I think this has been a brilliant webinar, and thank you very much to Claire and to Catherine in particular, who've set this up, and to all our speakers. I think the whole issue of remote consultation, assessment of the dying stages, and indeed bereavement care, that the primary care literature is beginning to address this, but there are particular issues in care homes and bereavement care that I think there's potential for research. So as part of the ARC National Palliative and End of Life Care theme, we are hoping very much to take forward work in this area in collaboration with Claire Goodman and the multimorbidity theme. So suggestions for research, comments, future discussions, please do put them either in the chat and or in the evaluation, and we will take that information forward. So thank you very much, everyone, for your engagement. The more comments, suggestions, the better. There's no wrong suggestions. We really want to hear what research would be useful for yourselves to improve care.
Thank you. Thank you, Stephen.
And Claire, over to you.
Just a final plug. The next seminar is going to be on research on visiting in care homes, and same format, completed studies, studies with early findings, and studies that are just getting off the ground. And delighted that we have Clarissa Giebel from Liverpool, we have Josie Dixon from LSE, and Claire Sir from Leeds Beckett, and Crystal Warmouth looking at the remote access, so picking up from that theme. So again, with the same emphasis, all right, what can we actually take from COVID to make things better, and not looking back to be able to improve future working. I think this has been a stunning group. I am quite taken by the echo chamber question. So I remember once a care home manager saying to me, actually, I think we're all right at palliative care. What I would like is someone to tell me how to release my nurses from the grind of the dispensing of drugs, which uses a very expensive resource for something. And so there's also that question about what happens if the priority doesn't fit with the researcher, but that's for another webinar. So just thank you so much. Please fill in that evaluation form. It will directly influence what we do. If there are things that you could have wished to have seen included in future webinars, please let us know. We try very hard to have a national reach. Delighted there are people from Taiwan who have been joining us and from South America. Please also remember the long-term care COVID website. If somebody could quickly click that in, that is a phenomenal resource for all things COVID research, ltccovid.org.uk, I think, or .gov. Somebody could find it. I would recommend that. I think we all bring in huge shared knowledge. So before I stray into 1535, well, thank you, Rena. It's there for everybody. So if you want to see any research on COVID and care homes, that is the go-to site. And delighted that everybody could join us. We will be sending you the recordings. We will try and curate a preprint resource of journals that have been cited. We acknowledge that the paywall barrier for some journals is a massive hindrance, so we will do our best on that. And please keep writing to us and let's make sure that excellence in Suffolk becomes excellence everywhere. Thank you very much. Okay, bye just now.
Thank you.